A lot of conditions in our body, a lot of orthopedic conditions happen because these tissues don't have the same blood supply that we might have in that skin. All these kind of tissues, they just don't heal the same way. Basically what we're doing is tapping into using platelets, using bone marrow cells, isolating those helpful cells from some of the other things that aren't as helpful, preparing them in a way that we can inject them, and then delivering them to these tissues where there's injuries to facilitate some kind of healing or repair of tissue.
Hello, everyone. This is Dr. Nita Lwanga on Empowered Wellness. I have my friend here, Dr. Derrington. He's a board-certified physical medicine and rehabilitation physician. He did a fellowship in interventional sports medicine, spine and regenerative medicine, and he is the medical director and CEO of Derrington Orthopedics. There are so many questions I want to ask you. It's very unusual to find somebody that has your background, PMR or physiatry, plus somebody who specializes in sports medicine as well, and regenerative medicine. This is a new field of medicine that's very exciting. So I'm so excited to have you on our show. Thank you for taking the time out of your busy schedule to talk with us.
Thank you so much. Thanks for having me. Yeah, I love what I do, and it is a niche that we can talk about more, but it's a great way to help a lot of patients out.
How did you get started? What was your background? Were you an athlete? I suspect a lot of people who go into physiatry were athletes to begin with or have an interest in sports medicine.
Yeah. A lot of people were either athletic growing up, had injuries growing up, something musculoskeletal wise that they want to be able to help others with. I played baseball and football all through college, ran track in high school. It's a very active mindset and try to stay active now. And I like the idea of being able to help other athletes. Like most former athletes, you go into med school and you think, I'm going to do orthopedic surgery, because that's really all that I knew. I didn't really know what this field was, and it was really just in its infancy. I was fortunate to get exposure during medical school to a little bit of regenerative medicine, and during different steps in residency, and then especially in fellowship, just even more exposure. So it was a nice transition from, as an osteopathic medical student, which we think a little bit more holistically, a little more tuning into what it can naturally do by itself and trying to augment that with physiatry or PM&R. We're trying to maximize how people can do things physically. And the things that we do now in my practice dovetail in with both of those approaches. And each of those steps prepared me for what I've ended up doing myself now for 8 or 9 years.
That is amazing. And do you think your training in osteopathic medicine steered you more in this direction, or how did it influence your career choices?
It definitely did. So as an osteopathic physician, you get a lot of extra training using your hands to diagnose, to evaluate. I actually did an extra year of fellowship during medical school, doing all those manual OMT treatments. So develop a lot of that palpation skills to do evaluations and potentially treat things. I've obviously focused more towards an injection-based approach to my practice, but those skills really helped me to be able to evaluate those patients. And a lot of DOs go into PM&R because of that hands-on manual component and that functional component. I actually didn't know PM&R existed when I started medical school, but it just was a natural progression that fit really well with what I wanted to do.
Yes, that totally makes sense. And I wish I'd known more about PM&R or physiatry when I was in med school. It's not something that I was exposed to until I did my fellowship in geriatrics. And as we have a lot of geriatric patients that have a lot of mobility problems, physiatrists help them greatly in terms of improving their mobility. And even if they have limited mobility, ensuring that we're fitting them with, say, the right prosthesis or the right wheelchair. Again, my experience was quite limited, but I found it so fascinating because my background is also pre-medicine. I was a gymnast, competitive gymnast, and all I knew was maybe sports medicine. Of course, I didn't go in that route, but I think PM&R and physiatrists are so instrumental in making sure people can stay mobile, stay fit, and they're getting the right instructions. I think, most of us, your non-PM&R colleagues, are doing things that you're probably like, what are you doing? Don't do that, please. Don't give that suggestion. Don't give people wheelchairs when they can do exercise to get stronger.
Yeah.
So
it's always a balance of working with what their limitations are at that time. Sometimes those can be permanent depending on what the injury is, but a lot of times it's helping them at that time be safe and be as active as possible, but then developing a plan as much as you can to be as active as independent as you can.
100%. And I think whether you're geriatric or not, movement is probably the best kept medicine to help everything. So after doing your general training in PM&R, you did a fellowship in interventional sports medicine and spine and regenerative medicine. How did you decide to go into that direction? Because that's very rare and very unusual.
Yeah, I knew going into PM&R that I was probably going to want to do different interventions, basically injections to help patients regain some of that function, reduce some of their pain. And classically, that's using steroids, doing ablation procedures where you're burning nerves, and you're basically temporizing symptoms for a period of time until you have to do that intervention again, or until they proceed to basically not working and needing to go to some kind of surgery. So I was fortunate that one of my residency classmates a couple years ahead of me did the same fellowship, and I got to see what she was doing. And I was like, that's really awesome. And it was really a hybrid of traditional interventional spine sports medicine treatment, doing some of those steroid injections, doing ablations, but also that introduction of regenerative medicine. So that's using things from your own body to help things to heal. That can be using platelets, concentrating them, making PRP or platelet-rich plasma. That can also be more cell-based treatments using bone marrow cells or adipose cells. People usually call those stem cells. We're basically using those to help things to heal. And when I had the opportunity to have that training, to really see both sides of that, it was just an opportunity I couldn't pass up.
Oh, I have so many questions, especially about the regenerative medicine, but I'm going to try to keep focused. For our audience, many of our audience members have never met a physiatrist. Perhaps they have a family doctor and they're having some challenges. What are some of the most common problems you help patients? Who would be your ideal client or your ideal patient?
So I guess one thing first, within physiatry, there's a range of specialties that you can have within there. So some of my classmates, they specialize in managing people with brain injuries or amputee patients or patients that have had strokes. I obviously deal with more musculoskeletal side of things. So the most common things that I see that walk into my door are people with back pain, people with knee pain, people with shoulder pain. And that can be from a variety of conditions, but they're dealing with those pains that are limiting what they can do. And they're oftentimes having to take medications to try to manage their symptoms.
Okay, so if I understand correctly, your ideal patient would be somebody who has, say, chronic back pain, chronic knee pain. They've been taking ibuprofen or Tylenol, it's not helping. They're trying to do all these things, resting, they're trying to do exercise, maybe they've done physiotherapy, and they're still not getting better. And maybe they're not so excited about or not sure if they need surgery, but they're really struggling. Is that?
That's a very common population that we see. I have some patients, and I live in Southern California. We have patients that are very active minded. They don't want to wait and go through the potential years of dealing with things and slow managing a problem. So some people come to me, especially once they know I'm around, very quickly, early on in the phases, and I can help guide from that standpoint. But definitely a large percentage of people have gone through the normal things and they're just not getting better. They're not getting the improvements that they want, and they don't like that next option, which may very well be a surgical option.
That's excellent. That is excellent. Can you tell us a story of one of like a memorable patient that you helped, maybe that had an unusual outcome?
Yeah. So like I said, I see a range of ages of patients. One guy that I saw probably about a year or so ago, dealing with the shoulder issue for several years. He's former military. He's actually active in the American Ninja Warrior TV show, if you've ever seen that.
Yeah.
And he had the shoulder issue that kept limiting him from basically doing very well in it because the shoulder was continuing to be an issue. So I treated him, and then I think about 6 months later, he went for that next show, and he messaged me afterwards, and he was able to do better than he'd done any of the other 3 or 4 times that he participated because his shoulder was feeling that much better, and he was basically having no issues with it. There's another gentleman that I recall. He's probably in his 60s, I believe, had back surgery before. Again, being in Southern California, likes to surf, but he had a hard time surfing very often. He'd be laid up for a long time afterwards, so he'd pay for it, but he still would go out and surf. I treated his back with non-surgical injections using the kind of regenerative medicine we're talking about. Now he surfs 3-4 times a week, can go on walks with his wife, and is basically just back doing the stuff that he was having a hard time doing. And it's always great to hear those kind of patients, especially the older patients who are like, I never thought I'd be able to do X again. And when you can open those kind of options for them, it's obviously very rewarding for them.
Absolutely. It makes a big difference and really impacts people's quality of life if they can't move. And then now suddenly they can do what they couldn't do before. And this is part of why we went into medicine, to help people. So when we see our patients having those positive outcomes, it makes some of the challenges that we go through on a day-to-day basis really worth it. So the next question I'd like to ask you is about regenerative medicine. For those who've never heard about this branch of medicine, could you break it down a little bit more? What is regenerative medicine? Like, you talked for individuals that don't have a background in science, you talked about PRP, platelets, different things that you inject. Yep. Break it down in really simple terms for us.
Yeah, so on a very basic level, we're tapping into what our body normally does well in a lot of places in our body, and we're using that elsewhere. Certain places in our body, like our skin and our muscles or even our bone, they've got really good blood supplies. They tend to heal well. You might have to rest for a while. You might have to put some bandages on, but things generally get better in those situations. A lot of conditions in our body, a lot of orthopedic conditions happen because these tissues don't have the same blood supply that we might have in that skin. So tendons and ligaments and cartilage in our joints, discs in our back, all these kind of tissues, they just don't heal the same way, which is why we have these degenerative conditions, degenerative rotator cuff problems, degenerative osteoarthritis. We even have a name for it in the back, degenerative disc disease, which is a combination of one part of the back kind of starting and then having all this cascade of things happening. So basically what we're doing is tapping into using components of that, like you mentioned, using platelets, using bone marrow cells, using sometimes even adipose, isolating those helpful cells from some of the other things that aren't as helpful, preparing them in a way that we can inject them, and then delivering them to these tissues where there's injuries to facilitate some kind of healing or repair of tissues.
That is fascinating, and that is very exciting. I'm trying to think back in medical school. I think we did, like in was it probably physiology, learn about some of these growth factors.
Yeah.
But just to see it applied to medicine practically is really exciting.
Yeah.
What are some of the new things that are coming down the pipeline in regenerative medicine that you're excited about?
We're learning so much over time now. This has been around now over 20 years in the United States. Some countries has been around longer than that. Actually, in equestrian, so in horses, they've been doing this for even longer. So I have a number of my patients who might own horses or work with horses in some fashion. Oh, we've known about PRP for years. So it's pretty cool just to see that transition from horses to people. But again, over time, we're learning a lot about how to use these tissues best, how to prepare them, how to deploy them in an injection-based manner, and what kind of things in these sources are valuable, and how do we optimize how we do things to make that be as positive of an injection for those patients.
Okay. Very interesting, very fascinating. And for some of our audience members who are not familiar with what we go through as physicians and, how stringent it is, what are some of the things they should look out for if they hear somebody does these kind of procedures with PRP, just to make sure that they're safe? Or should they make sure that the individual has certain credentials? What are some warning signs that this might not be the right person to take care of them?
Yeah, so great questions. A couple different factors to think about is one, who is doing the evaluation and who's doing the injection. So that person should have an orthopedic background. If you're dealing with musculoskeletal conditions, they should be an expert in that field. They shouldn't be a urologist or something that's not really related to musculoskeletal medicine and they just go, I can inject you in that area, it'll be fine. I think it takes a little bit different level of sophistication to really figure out specifically what the problem is and put together a treatment plan that makes sense. And then if they're going to be doing the injections, how do they do the injections? What training do they have for that injection? Do they do fellowships? Do they use image guidance to make sure that when you put a needle into somebody, which sometimes is several inches into the body, you're hitting millimeter targets. And if you can't see where you're going and confirm that you're where you think you want to be, you're not going to be as accurate. So you have some potential risk for complications if you're not being accurate. And also what you're injecting is not going to be where it needs to be. So your outcome is probably not going to be as good. So who's doing the injection and how they're doing it are very important factors. As I was mentioning a couple minutes ago, we're learning a lot about how to process these things differently to make them better. There's probably over 40 different systems that can create a platelet-rich plasma, which is basically putting more of the platelets in the liquid part of the blood, which is the plasma. There's probably a couple dozen kits that can make the bone marrow preparation. There's some that can make the adipose or the fat preparation as well. But how well each of those systems do that can vary widely. So your doctor, if you're getting a PRP injection, should be able to tell you more about, say, the PRP. What's the concentration? What is the dose? How many platelets are you actually delivering? What kind of a stimulus are you able to provide? Just like if someone's taking a blood pressure medicine that's supposed to be 20 milligrams, if you're injecting 5, or if you're taking a pill that's only 5 milligrams, it's not going to help your blood pressure near the same way as an optimal dose would. So if you're getting an injection that is underdosed, you're not going to expect to have the same kind of outcome. So if they can't tell you about the quality of what they're injecting, something about how they decided on why they're using that preparation, and even if it might be something that's different for you versus somebody who's a teenager versus somebody who's 80, there should be some customization in there. And that's something that we can do in our on-site lab that we have.
Oh, you have an on-site lab. Okay, that is amazing. And that means that you can really control what you're giving your patients. Wow,
Exactly.
that is...
Yeah, we're not confined to what one of these off-the-shelf kits makes. Even some of them can be pretty good. Some of them, I say a lot of them are not that good, but even the good ones, you're confined to whatever that prepares. My lab person, I tell him how much I want of different kinds of PRP, what concentrations I want, what preparations of some of the cell-based things that I want, and he back calculates how much we need And then we make a customized preparation for that individual based on their condition, based on their age, based on what I think is going to be most effective for them.
Okay, wow, that is fascinating. So it sounds like your approach is very customized to each and every patient.
Yeah.
Cookie cutter cookbook.
Right. Yeah.
That is awesome. Another thing that you touched on that I want to ask a little bit more about, you talked about, say, using ablation or other kinds of procedures besides PRP to help patients manage pain. Tell us a little bit more about some of these other ways that you manage pain.
Yeah, I've shifted away from doing those kind of traditional orthopedic treatments. So one of the things that's oftentimes used is cortisone or steroid, which is a way to reduce inflammation, reduce pain. For some people, that can be a very effective treatment. It can work for many months, sometimes even many years. Commonly, it's something that works for, in a good situation, 2 to maybe 4 months at a time. I see patients come in my office all the time that it works for a couple of days or a couple of weeks. Now, if it gives a long-term benefit, that can be something that maybe is worth doing. But if you have to do it over and over, one, it's a lot of visits to the doctor's office, it's a lot of time, but those injections are actually damaging to the tissues that we're injecting them near or into. So it's chondrotoxic, meaning it can be damaging to your cartilage. It can worsen underlying tendon or ligament problems. And oftentimes, even if you get a great response on the first injection, one of the subsequent injections down the road, you have less improvement, shorter duration of benefit, and you're just running out of options outside of having a surgery. Now, ablation, that's a fancy word for burning a nerve. So this is something that's commonly done in spine care when you have pain that's, say, coming from your joints in your neck or your low back. And that's a process where you basically put a needle close to where the nerves are and you burn them. So that pain signal can't go from those joints to your brain to tell you, hey, this hurts when I do that, which can be good to give you some relief of pain. But there's a couple different downsides there, of course, as well. One, you don't get that feedback that how I'm moving, how I'm doing this is aggravating. So when that nerve regrows, which it does at some point down the road, you've got a really irritated joint. A lot of times the pain afterwards is worse. There's also very small, deep muscles that are close to these nerves that are burned. In addition to burning the nerves, you're also basically cooking some of these muscles. And these muscles are important for position sense, called proprioception, and for fine movement in the spine. And if those muscles aren't working right in an area that's already not working right and painful, you have multiple things that are going on there, leading to what oftentimes is accelerated issues over a period of time.
Oh, wow, that is so fascinating. And it's interesting as a general internist, like I end up sending a lot of patients to our local chronic pain medicine clinic. And the staple treatment tends to be steroids. Yep. I've heard of some of my colleagues doing ablation. I haven't heard a lot about regenerative medicine. And you alluded to something, but I want to ask you maybe a little bit more clearly. You mentioned that you're moved away from the more traditional therapies. Is it perhaps, I don't want to assume, is it perhaps because of the side effects or is it because of the benefits? Tell us a little bit more about that.
It's a little bit of both. So one of the things that was really unique about my fellowship, like I mentioned, we were doing a little bit of both. We were doing a lot of the traditional non-surgical orthopedic sports medicine management, which, like you said, is oftentimes cortisone injections, ablation procedures, ideally in combination with good quality physical therapy. But from a procedure standpoint, those are the kind of things that are done plus or minus giving medications. And during my fellowship, I would see those patients coming back maybe every month for more medicines, every 3 or 4 months for another round of injections. And I got to see them several times over that fellowship. The patients who we were doing the regenerative medicine treatments on, I would see them come back. And actually, my fellowship was in Napa, so there's lots of wine around there. They would bring in bottles and cases of wine saying, I feel so much better now. Here's some wine, and here's my spouse, or here's my friend. Can you help them also? So you see this kind of diverging path of ongoing management, which is why it's called pain management, versus longer term improvement, if not fixing, of these kind of chronic problems that aren't getting better with the other kind of approach.
Ah, wow. That is very interesting. It's unfortunate, but it's also good that we have newer treatments that are more efficacious. But it's also unfortunate when you see people in whatever treatment they're having, especially like the steroid injections, not helping after a short period of time. Right. That can be very frustrating for our patients. The next question I'd like to ask you is, how do you know when it's time to send somebody to a surgeon? Say you've gone through all the regular modalities. How do you gauge whether perhaps you need to try something new or a little bit more unusual versus sending them to a surgeon?
Sure. So patients that come to me, I'm obviously seeing some of them that might have already been through all the non-surgical things. You might have had some of those traditional treatments. One of the benefits of the company that I'm affiliated with, we've got a 20-year registry of patients looking at pain scores, looking at functional changes. And within that, we get to tease out certain conditions that we know respond better to the types of things we do, and other conditions that we know based on the severity, based on the body area, what maybe doesn't have as high of a likelihood of improvement. So there's some things that I see right off the bat and I can say, I can't help you. You need to go see the surgeon. There's other things that might have a really good chance of improvement, and I feel very confident we can help them. There's sometimes things are in the middle, and I make sure that I'm clear with patients. This may or may not help. Here's some expectations. If you really don't want to have surgery, we can definitely try this, but appropriate expectations going into it. So if somebody is really trying to avoid surgery and it might be a reasonable option, then those kind of treatments might make sense. But if somebody is, I don't want to go through that, I just want to go have the surgery, then obviously that is part of it, because it takes a little bit of time and patience to get better from these kind of treatments, oftentimes shorter than surgery, but compared to a steroid, that oftentimes is a pretty quick improvement in symptoms if it's going to be helpful. It's a little more of a process. You have to be a little more bought in as a patient. You have to put the work in from the physical side of things. But those are things that really patients should be thinking about and then being educated on by someone that's offering these kind of options, so they know what their different choices are, what the expectations are, and they can make informed decisions.
Excellent. And I wanted to clarify, do you work with athletes as well?
I see a fair amount of athletes, and this can be high school, college, and some professional athletes. And then obviously a lot of patients as we get older, the 40, 50, 60-year-olds, we still like to think we're athletes. We're maybe not quite the same level that we used to be, but we like being active. We want to be more active. So pretty much all my patients are wanting to be able to do something more. It's not just that they have pain, which a lot of them do, but they want to be able to, whether it's get back into their season, whether it's play with their grandkids, whether it's just go walks on the beach, they want to be able to do something more. We're all athletic in some way, whether or not we're getting paid to do it or not.
That is great. So the last question I'm going to ask you, say, I'm just going to give you a scenario. Former dancer, I like to dance, and I'm not as fit as I used to be, and now I have injuries, and I'm looking for somebody to help me manage my pain. I've tried all the traditional things, rest, ice, compression, elevation. I've tried some steroid injections, and I'm looking for a physician like you that can help me. What are some of the things that I should look for and some of the questions I should ask before I decide whether this is the right specialist to help me?
Great question. So kind of like I mentioned before, a person with that orthopedic training really is important. I'm a little biased. I think physiatrists have a really good functional musculoskeletal orthopedic evaluation that we would do and we'd be thinking through. But you really need to have that. It's not just as simple as I come in with an X-ray or an MRI and say, here's my problem. As we know, there's lots of things that can show up on imaging that may or may not be relevant to whatever their pain or their limitations are. So being able to take the history, the examination, and the imaging all together and make an accurate diagnosis, not just relying on the pictures, that's step one. But then if you're looking at a more regenerative orthopedic approach, then you need to have some of the things we were talking about before of, have they had training on this? Not just do they know how to diagnose an orthopedic problem, are they an injection expert? Have they done courses on this? Do they teach in this? And then what they're injecting, how are they thinking about what they're injecting? How are they deciding between the different options? Why are they making those decisions? Now, it's hard for an individual who's non-medical. It's even hard enough just for physicians who, we know lots of stuff, but if it's not our field, we don't really know those details to figure through that. But asking some of those questions and seeing if that stuff makes sense, those are kind of things that you should be looking at to try to give yourself as much confidence that you are seeking care from somebody that can really offer good treatment.
That is excellent. And for individuals on our show who are watching and they have injuries and they want to work with you, they want you to be their doctor, how can they find you? How can they get a hold of you?
So they can get a hold of us a couple different ways. On our website, derringtonortho.com. Contact info is there. You can email info@derringtonortho.com. You can find me on social media, SoCal Stem Cell Doc on Instagram and on Facebook. And I get a lot of patients that come from out of town, and sometimes it's inquiries of, hey, can I help this problem? And there's a lot of docs that I know that do this kind of work. So sometimes I even help them find somebody closer to their area if there's someone that's excellent really near them.
We will make sure that we have your website and all your social media handles so that all our audience can get a hold of you and work with you. Thank you again so much for being on the show and taking the time to answer our questions. I really appreciate your time.
You're welcome. Thanks so much.
All right. Take care. Bye-bye.